All right. Hi, everyone. Thank you so much for joining today. Welcome to today's research seminar series on the topic of the mind-body connection. My name is Lily, and I'm one of the program assistants for the BC Brain Wellness Program, and I will be your MC for today. Yeah, thank you. And before we dive in, I do want to take a moment to acknowledge that the BC Brain Wellness Program at the Javad Moafane Center for Brain Health resides on the traditional, ancestral, and unceded territories of the Musqueam peoples. As a settler here, I think it's really crucial to recognize the profound relationships we have with the Indigenous peoples and the land, and to continue to honor and nurture these connections. It's truly a privilege to be able to offer our program on Musqueam land, and I know we're probably joined from various locations today, so I urge each of us to pause and reflect on the history of the land that you may inhabit. You can learn more through the resource provided in the chat. Okay, let's move on into introducing our two lovely speakers today, Dr. Amrit Dhariwal and Dr. Andrea Chapman. We are so grateful to have join us today. And a little bit about Dr. Dhariwal. She holds an appointment as clinical assistant professor in the Division of Child and Adolescent Psychiatry at UBC. She is also co-director of the Family Therapy Clinic at BC Children's Hospital, and her current clinical and research initiatives focus on helping families of children with various physical symptoms affected by stress. She has co-developed treatments, published peer-reviewed literature, and created knowledge translation products for public use. And the next speaker is Dr. Andrea Chapman. So Dr. Chapman is a psychiatrist at BC Children's and a clinical professor in the UBC Department of Psychiatry. She's also the director of consultation liaison service at BC Children's and the psychiatric service, which is a psychiatric service that works with children/youth admitted to the medical wards. And her area of interest is in pediatric somatization. So she has developed family and professional resources for pediatric somatization, participated in research on group therapy for somatization, and co-authored articles on this topic and the mind-body connection. So in today's talk, our speakers will explore the topic of somatization, which is when emotional or psychological factors, distress manifest as physical symptoms. So they will speak to how the mind and body interact in this process and discover and speak about valuable community resources that can support individuals experiencing this. And I would, of course, like to take a huge moment to thank all of our program donors for supporting the BC Brain Wellness Program. It's because of your generosity that we are able to offer these accessible events and classes. So as an entirely donor-funded program, we rely on your generosity to ensure the continuation and development of our program. So thank you, thank you, thank you for your ongoing support. And just a couple of housekeeping notes before we begin. If you have any questions for our presenter today, feel free to just type them in the chat box. If you want to ask your questions privately, just feel free to send them to me in the chat, and we will have a Q&A session at the end. And just please do keep your mics muted throughout the talk. This presentation is being recorded, but it will only be sent to those RSVP. It should be within 2 weeks' time. In addition, we are actively recruiting for two research studies. The first one is our Impact 360. Give me one second. Impact 360 study, and we are recruiting for healthy agers and those with Parkinson's to understand the health impacts of a combined virtual exercise, cooking, and mindfulness class intervention. So if you're interested, our email is impact.360@ubc.ca. And then furthermore, we have a new dietary intervention to understand the impact of diet on symptoms and the microbiome of those with Parkinson's. So if you are interested, please do send us an email at pd.diet@ubc.ca. If you know anyone who may be interested, it would be greatly appreciated if you can pass on the message. And these interventions are at no cost to you. And lastly, we have an in-person guided forest bathing activity at Pacific Spirit on June 26th from 1 to 2, and a talk on older adult mental health with Dr. Nellie Oak from UBCO that is happening on July 2nd from 12 to 1. So we will have just all the links and everything I said in the chat. All right, and without further ado, I will pass the mic to our speakers. Welcome.
Thank you. So am I sharing now?
And go ahead and share.
Okay. Is that good?
That's perfect.
Okay, great. So I'm Andrea Chapman, and Amrit Dhariwal and I are very happy to have been invited. So thank you so much. Today we're going to talk about somatization. And the road to getting better. So somatization is a very interesting topic. It's something that we all experience, both in health and in illness. And it's something that's very common in healthcare. So up to 20% of primary care visits have to do with somatization. Yet it's something that Western medicine is only now beginning to address properly and understand more thoroughly. So today, Amrit and I are going to walk you through our current understanding of somatization and treatments for somatization. So we work at Children's Hospital in pediatric somatization, and we run a group therapy program for children with somatization and their parents. And in this talk, we're going to be showing you some videos and slides that we use to help our patients understand somatic symptoms. And these are really oriented toward the pediatric population, but it's relevant for adults too. And we hope that you'll gain some understanding, seeing some of our materials. So I'm going to start with a video that we made a number of years ago to help people understand this complex area of somatization and why our bodies somatize. So in this video, there's three high school students, and they're worried about, one is worried about a math test, one feels rejected by her friends, and the third is an athlete whose coach is putting pressure on her. So I'm going to show a quick clip about this last student, um, and then we'll come back to the video after.
Okay, listen.
No, I'm fine.
Okay, Harriet, show us how it's done. We're counting on that rocket hoof of yours this weekend. We can't win this game without you. Now, what did I tell you about aim? All that power is useless unless you can hit the net.
Yes, coach.
Harriet, you gonna get that ball or what?
Huh? Oh, right away, coach.
Oh, great. We're gonna lose for sure.
We can't win this game without you.
Without you! Without you!
So we'll finish watching the video in a few minutes. It goes over more of the science behind somatization, but I wanted to pause and give you a few more details first. So somatization is the body's response to emotions, stress, and feelings. And somatization is normal and it's real and it's a very everyday experience. So we all feel our emotions physically in our bodies so that our bodies know how to react, what to do, and when we have different emotions, when we have different experiences. So every emotion is experienced physically in the body. And we love this slide because it really highlights how across cultures people feel emotions in different places, but similar. So the warm colors are where we feel and we are physiologically upregulated. So the yellows and the reds and then so things like shame, we feel it in our cheeks. So you can see the upregulation in the cheeks. Or when we're downregulated, which are the blues. So if you look at sadness, there's more blue there. And these are examples of everyday somatization. But we also know that emotions can show up in more intense and unusual ways. We think about somatization on a spectrum. So on the one end, on the everyday end, we have sensations that we can easily connect to emotions. So if you hear a loud bang, your heart is going to race, and that just makes sense. We understand that. In the middle are more time limited and less common physical sensations. And so that would be something like diarrhea after a big exam. So they don't happen all the time, but we understand that they're related to emotions. They're easy to connect. And then on the far end, we have atypical, very intense, or long lasting symptoms that are initially harder to identify as somatization. And these types of somatization might be things like having episodes that look like epileptic seizures but are not related to electrical stimulus in the brain. And they're an emotional response, or experiencing blindness without any eye or brain pathology, or feeling nausea and pain day after day. If when we're meeting our patients and parents, we often ask, where do you feel stress in your body? And most people can identify where do they feel stress. And so sometimes if you go around a room, everybody feels stress in different places. So for me, because I have migraines anyhow, my stress is usually going to come out as headaches, but I can have other kind of stress responses as well. And sometimes where you have a vulnerability is where the stress shows up. So I'm just going to go back to our video, and it's a couple minutes and you'll see how the doctor explains why we all have somatization symptoms and why these are very normal.
Well, the good news is that we ran quite a few tests, including blood work and an ECG, and everything came back normal. Has this kind of thing happened before?
Yeah, I guess a couple times, but I don't get it. Why did all this happen if the test results say I'm fine?
I know it's hard to understand why you are having these kinds of physical symptoms when nothing is wrong with your body, but these episodes are still very real. You're not making them up, and they're not just in your head. These reactions are the result of the communication between your brain and the rest of your body. This is called the mind-body connection. Let me explain the science behind that. The fight, flight, or freeze responses are a great example of the mind-body connection. When we sense that we are in danger, a very powerful physical response is triggered. This can happen anytime we feel really scared, like running into an angry animal or a soccer ball flying towards your face. Believe it or not, the same thing happens even when the stress we experience isn't life-threatening. The nervous system has two main parts, the sympathetic and the parasympathetic systems, which are always acting in balance. The sympathetic nervous system is like a gas pedal in a car. It tells your body to activate. The parasympathetic nervous system, on the other hand, is like the brakes in a car. It tells the body to slow down. The fight, flight, or freeze response is the sympathetic nervous system sounding the alarm. It all starts with your ears, eyes, and nose picking up a danger signal. Your brain makes sense of what's going on around you and decides what to do. Then it sends commands to your body using electrical and chemical signals. These signals tell your body to act now and to stay alert to stay alive. Lungs breathe faster and shallower to take in more oxygen. The heart beats faster and harder, pushing the oxygen to your brain and big muscles so you can fight back or run away. Pupils dilate so you can see better. Hands and feet feel numb or tingly because your blood is being sent to other places in your body that are more important for survival. For the same reason, the stomach slows down because it doesn't need to digest food when your life is in danger. So, when your brain senses danger, a whole bunch of bodily reactions happen quickly and without you even knowing it. Then, when the danger is gone, your parasympathetic system kicks in and tells your body to calm down because even though these physical symptoms are not dangerous, they can be very powerful and problematic if they go on for too long. Often we aren't aware that our normal emotions can trigger physical responses in the same way as life-threatening danger. Daily stress from tests, the sadness of rejection, or feeling overwhelmed with responsibility are all very normal examples of emotions that can trigger a physical response through the mind-body connection. Sometimes the symptoms are caused by stress and emotions on their own. Other times, there is a medical condition as well, and stress and emotions make the symptoms stronger. Often treating these symptoms begins with learning about the mind-body connection. When we come to understand that the symptoms are real and powerful, but not dangerous, we can take steps to make things better. Like anything powerful, these symptoms can be overwhelming. But when we take the time to understand the mind-body connection, even though it can be tough, we can learn a lot about ourselves.
So the fight, flight, or freeze response is a good example of somatization. And we spend a lot of time really helping people understand the physiological nature of somatization, because typically along their journey with physical symptoms or somatic symptoms, people have heard it's all in your head or you might be faking it. And we spend a lot of time making sure that people understand that we know these symptoms are very real, and we're working very hard in the medical community also to convey that information. So I have a question for people. So how many of you have ever had a physical symptom and wondered if it was due to a concerning medical problem or if it was related to an emotion or stress? And I know for me and people in my family that that's a common question that we have. And it's a good question to have. So we think about that a lot. It's very important, of course, when you first have a physical symptom to have a good and thorough evaluation. And at the same time, when with certain clues about symptoms or after results come back, it's also important to know that somatization is very common and real. So we think it's really important to keep a mind and body perspective in medicine. I'm going to explain that just a little bit more. So your body is that physical structure of yourself. So your muscles, your bones, your organs, all of those things. And your mind is that the element of yourself that's a bit more elusive, and it allows you to experience life, to have consciousness, awareness, to have goals and dreams, imagination, thought. And your mind and body are always working together. We all know that. And with your brain as the command center and the bridge between the two. So your brain processes information from your body, and it processes information from your mind and then makes decisions based on those signals. So sometimes those decisions are voluntary. If your stomach is empty, you get a hunger signal, and then you voluntarily, your brain tells you, and you voluntarily go and get some food. But a lot of times those decisions are involuntary as well. So if you hear a loud noise, your pupils are going to dilate and your heart will speed up without you making a conscious choice. So again, both mind input and information from your mind and from your body is very important. And when we have long-lasting physical symptoms, we sometimes wonder, is this more mind or body? And what we know is that sometimes we know it's more mind, sometimes we know it's more body, but often mind and body can't be separated, and a both and perspective is more useful. And both mind and body information can affect physical symptoms. So like I said, there are times when, like a panic attack, that's more of a mind symptom that affects, that's anxiety, it affects your body. A femur fracture, having the flu, those are more structural problems, and those are clearly more body problems. But there's many times that there's a both and perspective where you could have something like irritable bowel syndrome or migraines where there's medical and physical components to those, and stress and emotions influence it as well. So I'm just going to take a couple more minutes to talk about what causes somatization, and then Dr. Dhariwal is going to talk about treatments. So we've talked about what somatization is and how physical symptoms can be caused by both mind and body at the same time. But what are some of the things that cause somatization? So this is just a graph that shows you that many, many things can make a person vulnerable to somatization. So that could be things we tend to, people that are very kind and caring and sensitive, their bodies are more sensitive. So they might, we find that they are more likely to have somatic symptoms. If you've had trauma in your past, or if you're currently going through stressors, if you have a medical illness. So there's lots and lots of vulnerabilities to things that cause somatization. So we see lots of children where their symptoms start off as a medical condition, like gastritis, and then over time, the symptoms have more of a somatization element, sometimes as stress and emotions build up. And other times, we certainly have lots of patients where psychological stressors start this somatization off. And then that can build up and can keep the physical symptom going. One, we won't talk about all the causes of somatization, but predictions are really interesting. I thought that your group, this brain wellness group, might be very interested in this. So, predictions are the beliefs that we have that are really based on our past experience and information that we're getting from the environment. So, I can be in a certain situation and have a different prediction about what's going to happen than another person. And that actually affects our physical symptoms too. So that they can play a big role in how we process sensory information. So I'm going to play a clip. And this is from an interview with Dr. Rachel Zoffness, who's a pain specialist at University of California. And this story illustrates how powerful predictions can be.
Point.
So tell me the story of the two nails.
Great. So, 2007, Journal of Psychosomatic Medicine reported on two gentlemen. They were both construction workers because apparently that's the most dangerous job anyone can ever have. So, one was a 29-year-old construction worker, and he was on a job site, and he jumped off a platform straight onto a 7-inch nail, and that nail went straight through his boot, clear through to the other side. And he was in terrible, excruciating pain. And his colleagues were all horrified, and they rushed him to the emergency room. And, he was screaming with pain, and they gave him an IV of intravenous fentanyl, which is a very powerful opioid, as we all know. And the good doctors removed his boot, and they discovered that a miracle had occurred. The nail had passed between the space between his toes. There was no blood, there was no wound, there was no tissue damage, but his pain was real. How is that possible? His brain, aka his danger detector, used all available information. Memories of past pain experiences, knowledge of the dangerous work environment, the panic that he saw on his friends' faces, this visual, of course, his 5 senses, this visual of a nail sticking out of his boot. I also would freak out. And because
I feel pain just hearing the story.
yeah, and because his brain decided that his body was in danger, it made pain to protect him. So, second tale of nails. And by the way, of course, I like stories that rhyme. I call it a tale of two nails. The second story, another construction worker was on a job site. He was somewhere in Colorado, and he was using a nail gun. And the nail gun accidentally discharged, and it ricocheted backwards, and it clocked him in the jaw. And he had, a mild headache and a mild toothache, but he continued on with work and life for about 6 days. And at the end of 6 days, he turned to his wife and said, I'm going to get this toothache checked out. And he went to a dentist, and the dentist did a scan of his patient's jaw. And much to both men's surprise, they discovered a 4-inch nail embedded in his face. Right. And what had happened was when the nail gun discharged, he saw a nail shoot across the room and bury in the wall across from him. So again, his brain, our danger detector, used all available information to determine whether or not to make pain and how much. So it used this visual of this nail shooting across the room and information also of this experience of having this nail gun clock him in the jaw, and decided that not much pain was needed because his body ultimately was safe. And I read this, I went down this rabbit hole with these stories so far. You have no idea. I have a collection of every interview, everything. And one of the doctors who finally did the surgery to remove the nail said something like, he's the luckiest man I've ever met. So again, Ezra is shuddering, everybody. So again, to me, what I really love about these stories is that they illustrate the point, pun intended, that I'm trying to make, which is your brain is always using all information, not just some information. Pain and tissue damage are not the same thing. The conclusion of the tale of two nails is you can have damage to your body and not a lot of pain, like a nail, 4-inch nail embedded in your face. And you can have no tissue damage and have a lot of pain, like our friend who had the nail in his boot.
So I'm just going to ask Amrit, what do you think? I have, okay. I just texted Amrit. She said it's okay to show this video. So when we first meet kids with somatization, we often don't know exactly what might be causing their somatization. And we use this bucket analogy to start us thinking about possible factors for each person. So we think about what stressors might be filling their bucket, things like internalized worries, pressure to do well, medical illness. And when your bucket is overflowing, you can have lots of different ways of coping, but your body can unconsciously cope by having somatization symptoms. So I'm just going to show this last video quickly, and then we're going to turn to Amrit to talk about treatments.
Stress is usually seen as something we need to avoid. This is not true. We need stress, and we need our body's stress hormone cortisol to rise and fall throughout the day. Stress helps us wake up in the morning, helps us focus, learn, and remember new things. It's when people experience too much stress and start having difficulties coping that stress becomes a problem. High levels of stress can disrupt the natural changes in the body's stress response system and start to affect our physical and mental health. Over time, accumulated stress can result in false FFF response activations. When trying to measure our stress tolerance, the bucket analogy can be helpful. Our stress tolerance, or the size of our bucket, is a product of our genes, personality, and life experiences, and its size varies from person to person. The water in this analogy is the combination of all the stress in your life. We use the coping strategies we have available to keep our bucket from overflowing. They are like taps that allow water to drain from the bucket. Stress can include training, work, school, relationships, finances, moving, changing jobs, or the loss of a loved one. Both positive and negative experiences will affect the water level. A big bucket can hold more water or stress before it overflows. With a smaller bucket, less water is required for the water or stress level to become critical. While you can't change the size of your bucket, you can make life adjustments to reduce water coming in. You can also learn new coping strategies and stress management techniques to allow water to drain out. Mind tools, exercise, quality sleep, relaxation, and sharing your feelings with friends are some examples of effective water taps. Staying up late, sleeping in, drugs, inactivity, procrastination, suppressing or ignoring problems are examples of unhelpful coping strategies or false taps. They might give temporary relief, but actually result in water flowing back into your bucket.
Hey, I'm going to stop sharing, and then Dr. Dhariwal will share. I'll hand over to her.
You can see my screen. Okay, great. So thanks so much, Dr. Chapman, for giving us that foundation. So I'm going to carry on with talking a little bit about strategies and treatments. So what we have here is a 4-phase roadmap for care that we developed along with our colleagues at a couple of other pediatric hospitals, so Sick Kids in Toronto and Alberta Children's in Calgary. And over the years, as we've cared for a lot of people affected by somatization, we realized that there were actually these 4 phases in their journey, and you can consider whether this is a useful roadmap for you. So at the start, we found out that confusion is almost always there, and people wonder, why are my symptoms lasting so long, or why are they so disruptive? And they can start to feel really unsure, and even doctors sometimes struggle to explain what's happening. But confusion or worrying doctors have misunderstood or have not fully grasped the struggle turns out is a very normal and expectable part of the process. And so for us, we've realized that recognizing the confusion actually helps us learn what to do. And so most importantly, at the very beginning phases, our strategies really focus on hearing people, understanding them, and reassuring them that their concerns are being taken seriously. The second phase is the connections phase. And over here, families, patients, and professionals, they all begin to share an understanding of how stress and emotions relate to physical symptoms. In this situation, you feel like you have a diagnosis that feels right, and your family and your doctors see it the same way. And then we move into the phase of treatments. And the core treatments that we provide in our work here at children's hospitals can be grouped into two strategies. So we have the psychological treatments, which are really focused on managing emotions and difficulty with emotions. And then we have behavioral strategies, which really focus on daily action plans or habits. The two approaches do tend to overlap, and there's no one right order. They can be used together or at different times, depending on what you need. We like to think of it like a tree. So the roots represent your emotions and your inner world and what's going on beneath the surface, while the branches are your behaviors and everyday choices and activities, or the parts that other people can see. And so sometimes it makes sense to begin with the branches, especially when they're easier to spot and adjust. And other times it's the roots that need care and nourishing to help the whole tree grow stronger. So let's start by focusing on the roots first, or the psychological strategies first. So you just learned from Dr. Chapman a little bit about somatization, or the experience of emotion in the body. So if emotions show up in the body, this tells us that they're biologically important. Somatization isn't some kind of mistake or a random side effect of emotions, but they actually serve a survival purpose. It helps you act automatically in important situations. So if you take anger, for example, if someone hits you or insults you, you might tense up and release adrenaline. Basically, your body has gotten prepared to defend itself, and really importantly, it's done this without you consciously deciding to do so. Your body may not have even labeled this feeling as anger yet. And this is because your body bypasses the brain's thinking centers, which are deliberately slow and analytical. And if you had to think first, like, is this person going to hurt me? Should I hit back? Should I run? You'd be too slow. So this body first reaction, it's a built-in survival mechanism that ensures you act before your brain has time to overthink. Another concept that helps make sense of things is allostatic load. And this is the scientific word for wear and tear that stress can do to the body. Maybe you've heard this metaphor before, but if you imagine holding a beach ball underwater, at first it's light and easy, and as long as you hold it underwater, the surface is smooth and serene. But the longer you hold it, the more tired you become and the harder you have to work. And it feels like the ball could pop up at any moment. So stress is like this beach ball. Over time, this beach ball of stress can make you feel tired or even sick. And your natural bodily functions don't go back to baseline or normal. So just remembering what came up in the stress video or the stress bucket video, the idea is that your cortisol reactivity can adjust and result in things like pain sensitivity, GI problems, fatigue, twitching, weakened immunity, and much, much more. So it's like holding that beach ball underwater, manageable for a short time, but exhausting over the longer period. And so when stress is prolonged or repeated, it's very hard on the body. And over time, the physical symptoms can become long-lasting. And so the human stress response isn't purely psychological. In fact, cortisol is released in response to both physical and psychological stressors. And the body doesn't distinguish between a biological danger, like an injury, or a psychological conflict, one like a conflict with another person. And so stress can activate both of these pathways. So this means we think of emotions like energy in motion, and literally that's what the word means. As life shakes you, your emotional energy builds up and creates internal pressure, like the shaken pop bottle. And over time, if you don't unscrew the cap to release the emotion, the pressure stays trapped. But what the body actually needs is motion. The emotions are there to move you. That's what they're designed to do. So when emotions get bottled up, the brain might redirect the energy in surprising ways. So I'm not sure if you've ever experienced any of these, but a sudden emotional outburst, like exploding over something small, or shifting into an emotion that's easier to handle, like laughing when you should be crying, or getting angry when you're actually scared, as well as bodily symptoms like tension, pain, gastrointestinal problems, fatigue, thinking difficulties, and motor difficulties. Basically, when there's an overload of emotions, your system needs a way to safely unscrew the cap and let a little bit of the fizz out. So everyone sometimes has unwanted emotions, and there's painful emotions like fear, anger, sadness, hate, and embarrassment, and many more, but they can be very uncomfortable and they do take time and energy to sort through. And most people would rather be experiencing pleasurable emotions like love or happiness or hope and trust and confidence, which can be much more desirable to have. So many of us will try to ignore the painful emotions and focus only on the pleasurable ones. But unfortunately, in our brain, emotions aren't like a dimmer switch. You can't just dim one feeling or just the painful feeling. And in our brain and in our bodies, emotions aren't neatly separated into good and bad. And we have to use the same neural pathways to feel all emotions. So sometimes what happens is if you dim the pain, sometimes you dim the good stuff too. And so at some point or another, we all resist our feelings. But it turns out resisting painful emotions actually makes them more powerful, more intense, and more prolonged, like the shaken bottle. And the powerful emotions stick to you. And sticking is usually the opposite of going away and not usually the intended outcome when you bottle them up or hold them in. So this brings us to the difference between having feelings and feeling your feelings. So having feelings means the emotions are there somewhere inside you, even if you're not fully aware of them. You can imagine emotions like music playing in another room. Having a feeling is like the music is on, but the door is closed. You might not notice it clearly, but it's still playing. While experiencing emotions means you're actually noticing them, hearing them, and allowing yourself to feel them in your body and mind. And so it's like opening the door to the music, listening to it, taking it in, and maybe you're even humming or dancing along. A common trap is mistaking thinking for feeling. When you analyze an emotion, you actually are not in it. You take a step back from it. You look at it as though it's happening to someone else, observing it rather than inhabiting it. And thinking about feelings, it's sort of like receiving a typed description of the music rather than actually hearing it. Analyzing emotions, tracing their origins, naming patterns, and seeking meaning, those are helpful things and they can help bring clarity, but it's only part of the process. And I'm not sure if you can relate to this, I certainly can, but you can understand your entire story inside and out and still feel heartache. And this is because emotions aren't just stories or memories. Emotions carry that biological information, which we talked about already, and show up in the body. So the physical sensations can't be reasoned away or ignored. So controlling, intellectualizing, or solving emotions, those aren't the same things as feeling them or surrendering to them. So we really like this phrase, feel it to heal it. It means healing happens when you turn towards your pain rather than turning away from it. And it's like taking your armor off, but it's the very armor that might have actually once kept you safe. And so this is a very difficult thing to do, and it's not something you can do just because we've given this presentation. Often these are the kinds of strategies we use when we work with people one-on-one or in family therapy here at Children's Hospital. In the beginning, it's very hard to trust that you don't need the armor, and your brain may actually try to convince you that if you just control your feelings, you will be better. But as we've been discovering, the opposite can actually happen, and the unfelt feelings just worsen. In our work, this is where we introduce different strategies to manage emotions. People typically use one of three strategies. You can be like an iceberg, and I think this is the more common one amongst everybody. The iceberg is a down-regulating strategy. The iceberg hides emotions by pushing it down, and under stress, you hide feelings or you hide your need for help, but on the outside, you might even look calm or even cold. So you might do things like distract from emotions, you might say they're no big deal, you might ignore them, you might even joke around if you're anything like me and pretend they're okay. And on the other end, you can be more like a storm, which is an upregulating strategy. The storm hides the emotion by very quickly spinning it around. And so under stress, the person feels a confusing swirl of things all at once, which prevents clarity or relief. You might do things like self-blame, overanalyze, pressure yourself, and this only intensifies the emotion. So we compare these two maritime metaphors with a third metaphor of the lighthouse. Many think of a lighthouse as a source of safety, and the lighthouse is a reflective stance because rather than hiding away or instantly reacting, you pause and you shine a light on your feelings so you can understand them. And so you're really trying to make sense of the waves. And like a lighthouse, this strategy can help you see clearly when you're on the waters. You can steer your ship instead of crashing into an iceberg or getting lost in a storm. So in our work, this is where we teach ideas like being with. This might be something you've heard of before. It's very common in a mindfulness approach or an attachment-based approach. Essentially, being with means staying present to emotional experience. It could be your own emotional experience, it could be your child's emotional experience, or anyone else's emotional experience. So being with means you're sitting with it without avoiding it, overanalyzing it, fixing it, or judging it. You're basically saying, this feeling doesn't need to be fixed. This feeling is here for a reason, and it needs to be felt, it needs to be named, and it needs to be made safe. Being with isn't a solution that fixes the emotional distress all in one go, but it's a practice that over time helps build the emotional muscle. So over time, the effect is that emotions increasingly feel tolerable. And it can prevent emotional escalations and make it easier to solve problems. So being with emotions can be helpful, but before we go any further, it's essential to highlight that this isn't something that any one of us can do all the time. So do not aim to do this 100% of the time. It would eat up your whole day, and it's not humanly possible. So instead of pressuring yourself to be with emotions all the time, what we often recommend is to see if you can use it during strategic moments, those emotionally hot moments where you just don't know what to do, when you feel at a loss, to see if it helps in those moments. So the reason the lighthouse or being with helps, you may have heard of this phrase too, this name it to tame it idea, which is sort of another thing similar to feel it to heal it. But it's one step over. So it means that by labeling an emotion, you reduce its intensity and you gain control over it. And actually, there's a lot of neurobiological evidence that this works. So this is an image of an upstairs brain and a downstairs part to your brain. And the downstairs brain here is online at birth, and it's responsible for things like emotions, survival instincts, and fight or flight. And the upstairs brain it's actually under construction sometime well into your late 20s, so like 28 or something on average, they say. And it's responsible for logic, reasoning, decision-making, impulse control, and emotional management. Now, normally the upstairs and downstairs, they work together, but when you feel an intense emotion, the downstairs instinctively hijacks access to the upstairs brain, and it shuts a gate between the two areas. And this is why emotional reactions like the storm or the iceberg bypass logical thinking. And that's why name it to tame it can help. So when you name an emotion you're having, or when you attempt to name it or put words to your experience, what you're doing is you're reopening the gate and connecting the two parts of the brain. The thoughtful upstairs brain can use the logic and organization of language to sort of make sense of the more abstract, jumbled, or emotional downstairs brain. So name it to tame it works because naming the emotion helps shift your brain from being caught up in the storm and stepping back to look at it. And it's like giving your mind a handle to hold on to so you can observe what's happening more clearly. And this creates an experience of calm or relief. You can think through your actions, you can calm yourself, and you can respond in a measured way. So next we want to just shift to the branches of the tree, or exploring the activity participation through the behavioral treatment lens. And this is where in our work we normally introduce rehab medicine, which is different from acute medicine. So at first when symptoms appear, acute medicine makes sense. You stop your activities, you get help, you get a diagnosis, and you find treatment. But when symptoms persist or are shaped by somatization, rehab becomes the key to moving forward. So in acute care, you're like a passive patient, and the experts take charge. They use tests and medicines and procedures, things that can work spectacularly but carry risks. But in rehab, you're actually in the lead, And the providers become more like guides or consultants that help you find the tools that fit for you. Now, rehab treatments are hard. They focus on exercises to gradually get you back to meaningful activities, but they can be slow, and that means you might not see very big payoff in the early days. But the more you do them, the more they work with lower risk and longer term benefits. Sorry, I'm just noticing. So the key to remember with rehab medicine is that you do things even when you have symptoms. You're not waiting for the symptoms to go away before you engage in activities. So it's like doing the opposite of what your symptoms tell you to do, like going for a walk when your symptoms tell you to hide. And it's the action that shifts the symptoms. Now, it might seem very paradoxical to face discomfort rather than avoiding it. You're swimming towards the shark rather than away from it. So instead of saying, is this TV quiet enough for me? You're asking, is this TV loud enough for me? Or instead of, are the lights dim enough for me? You're asking, are the lights bright enough for me? Now, this approach doesn't mean you should just force yourself to do the hardest thing. It's not a just do it strategy. It's like the tortoise and the hare. We're not talking about pushing through at full speed like the hare who raced ahead and then burned out and fell asleep. We're talking about the consistent, gradual, and steady approach like the tortoise who kept moving forward bit by bit and past the hare. So we call it start low and go slow so you can build momentum in a sustainable way. So there's 3 different ways that we introduce these ideas. You might be familiar with some of them. Graded activity is a very common one, and it's a way to build up your strength and stamina slowly and safely. It's a way to respect your body now and help you grow from there without overwhelming it. Instead of doing a lot all at once, which can make you feel worse, you start with a very small amount of activity that you think you can handle and gradually increase over time. So it's like climbing stairs. You don't leap to the top, you take one step at a time. And as your body gets used to each step, you gradually then take the next step. So maybe you add a minute to your activities or a few more variations, or you do a slightly harder version in some way or another. So an example for a graded activity for a university student with brain fog might be just start by opening your book to page 1 day a week for a week. No reading, just getting into the habit of opening and closing. And then stepping up to spending 5 minutes looking at the first page. And then spending 15 minutes for however long you can to read a bit of a chapter. And eventually you very slowly work your way up to being able to handle a whole class. So you only move up one step once the current step is successful, and you have to wait for it to be repeatedly and consistently successful before moving up. The second strategy is called habit stacking, and this is just a special way to make schedules or routines for yourself so that they stick. For some of you, your brains and bodies might use a lot of energy each day to debate whether to do something and then negotiate how and when to do it. And this keeps your brain and body guessing about how your day will go, which only increases fatigue. So habit stacking takes you from pushing yourself to remember to building an automatic rhythm. Essentially what you do is you attach small helpful activities to things you're already doing, so it becomes part of your rhythm. So it's like setting up a playlist. You press play and your day just flows. So you build a routine to anchor your day around meaningful activities rather than how you feel. So this way it's not about motivation, but about routine. So for example, imagine you already have the habit of brushing your teeth every morning. This means you already have an anchor habit, or the red box at the bottom of the picture. You can now stack on a new habit, like stretching your neck for 2 minutes next to the sink. So maybe that's all that there is to it, or maybe you eventually want to start stacking more parts to your morning routine. So habit stacking slowly and gradually creates structure and predictability, 2 things that the brain finds calming. And the brain builds new neural connections between the existing behavior and the new one so that it eventually becomes a habit. The last strategy that we talk about in our work is the symptom spotlight. And it's a way to check in with your body, like using a traffic light to guide your day. So green is a period before symptoms start or before they intensify, where you might have some early warning signs. Yellow means your symptoms are there, but they might not be intense yet. And red means you're in a full symptom flare or the symptoms are really intense. And it's especially useful if you have unpredictable symptoms because not knowing what to do during symptom flares can be really overwhelming and scary. So if you imagine that you have headaches and nausea that seem to hit out of nowhere without any warning signs, what you would do is you would start by tracking episodes in a journal to find out if any subtle patterns emerge. And you might discover things that you haven't noticed before. For example, 30 minutes before a flare, you might notice you feel a bit foggy, or you yawn a lot, or you become thirsty, or you notice a faster heartbeat when you stand up, or you might become overwhelmed in bright, noisy spaces. They could then make the green light. So you can make a plan then at the green light to sort of pause, hydrate, sit or lie down, dim the lights, and slow your breathing before things get worse. The plan can include what to do, where to go, who to call, what to say, which activities to stop. And often these warning signs don't feel like they're part of the symptoms at first. They can just seem like background noise. But once you recognize them, you can have a greater sense of control. And so using this system helps you tune into your body early and take the guesswork out of what to do. Responding early might not eliminate the symptoms totally, forewarning, but they can really avert a full flare often or decrease the intensity of symptoms. We have a few tips for getting the most out of these kinds of action plans. So not springing a plan on someone, but really developing carefully, planfully in advance. Staying in charge of your own plan so someone's not doing it to you. Making sure you have someone to guide you, like a helper who can help you troubleshoot moments when you're stuck, but you stay in charge. One of the most difficult things I find people doing is they struggle to find the right starting place. They often start too high, but the starting place is something you can do on schedule every day, 5 or 7 days of the week, even on your worst day, a full symptomatic day. So focusing on consistency matters much more than intensity. And avoiding big jumps, because big jumps can damage trust in the process. It's always okay to revise the plans if you found out that a step you expected to be okay was too big, and you just follow the plan rather than following your symptoms. So now your symptoms aren't in charge, but you're in charge. You can expect some painful emotions to emerge because the progress is slow, but it's really helpful to notice the progress, to track it, like maybe visually on a chart, and not to punish progress. So being successful doesn't mean that the symptoms weren't real, and it's really good to avoid the frame of "see, you can do it" kind of thing. And it's important to make sure other people know what your plan is so they can not escalate things for you. So action plans are meant to follow a gradual path. This is very different from the all or nothing path. So when symptoms are really strong, the patients we see here are highly motivated to get better. They want their symptoms to go away quickly, but the progress can sometimes be painfully slow. So for example, if you're an athlete, it can feel intolerable if you can only walk 5 minutes before you get dizzy. So that then you might go all in to overcome your symptoms. And on this side of like all or nothing thinking, you might tell yourself things like, I need to do more than my doctor recommended because I want to get better right away. This is taking too long, so I need to work harder, or I need to push myself beyond my limits. And then eventually you burn out, swinging the pendulum back to inactivity, saying things like, I'm so tired of this plan is not making my symptoms better, it's making them worse, I don't have anything left to give, and so on. So we call this boom or bust, and it's and compared to like the gradual path, is slow, and there are shades of gray in healing, and you might notice that healing doesn't follow a straight line. But if you stand back, it's hard to notice it when you're zoomed in, but if you stand back and look at it over a period of weeks or even months, you can see that it actually gets you towards your goal faster than the all or nothing approach. So I just want to go back to this map. So the final phase is well-being. Which is not based on the presence or absence of symptoms, but it means that you're participating in your life even if you have symptoms. And so here are a few categories of wellness that we've learned about from our patients, and mostly feel like people want to feel productive, they want a sense of belonging, and they want to have happy feelings too. And at the same time, we've also noticed that they also there's also bad things that happen when you're well. So having those there and being able to tolerate them. So the 4-phase map is uniquely yours. It might look different from another person's. So the 4 steps we showed are in a particular order, but they can go in any order. So we're at 12:56, and that doesn't leave a lot of time for questions, but thank you so much for having us. And if there are questions, we can be around for a bit.
Sounds good. Thank you so much, Doctors Chapman and Dhariwal. Let me just take a quick look. I think someone left a comment, visually track question mark. I'm
Oh, right.
assuming, yeah, if you want to elaborate more on that, I think that's what they.
Yeah, so those two, maybe I can go back to sharing screen. So can I just go here? Can you see that? So let me just go back up. So visual tracking, it's sort of like you're monitoring that whether you're consistently doing something over time. So rather than monitoring it, I guess what I'll say is if you track it each day it might not be very different from the day before. But if you stand back and you look at your progress over the longer period, then you can often see success, even though if you look at it within a few days, you don't often see it. So I think that's all I meant, is noticing your improvement over time.
All right, perfect. Thank you so much. And yeah, someone said that I would like to hear this all again. We will send the recording to those RSVP'd, so it should be available in about 2 weeks. I think someone also asked, I know you both work with pediatric populations, but is this something like is treated and that's common in adults as well? And are there any ways to, I guess, like receive help for older adults in this area?
So Andrea, I know you're talking, but you're muted.
Thank you. That's a great question. Yeah, this occurs for all of us. So in pediatrics and adults, and often in chronic illness and in many different ways. There's not a unified way service, like there's not a somatization clinic or a mind-body connection clinic, but we are building more and more services. UBC neuropsychiatry is a group that most commonly will see patients with really, really very significant somatization. And then there are some other psychiatrists, and certainly lots of specialists have some expertise in it, but we don't really have a unified clinic, unfortunately.
Okay.
We are, I think that everybody's skills and understanding is building over time. There was a question too about the metaphors. So the lighthouse, the iceberg, and the lighthouse in the middle, and the storm. And somebody had asked, Tracy had asked, can you have all three? And I just wanted to say absolutely. And so we always ask our youth in the group, and then we ask the parents, like, what are you? And lots of the people that we work with that tend to have more somatization tend to be more the iceberg style, but there are also a good percentage that are the storm. And then there's people that are mixed, and it can depend on kind of where you're at or day to day. And then, of course, people have some of the lighthouse too. We keep working towards more and more lighthouse. That was a great question.
All right, thank you so much. Can the stress of caregiving cause somatization?
Great question. Amrit, do you want to take that one?
So if I understand it, can the stress of caring for another person? I think any kind of stress could be underneath there. We all have different lives and different kinds of stresses and different things that we experience in our bodies. So certainly I think caregiving for another person should be one of the highest ones up there. It's the hardest thing I do, I would say, in my life. So
Absolutely.
All right. Thank you so much. Maybe we have like maybe 2 or 3 more. We'll take just 2 or 3 more and then we'll just close the event. Someone asked if you have a chronic illness, autoimmune disease, or both, can it be difficult to tease out the emotion slash mind versus the symptom? Like, how do you make that distinguish? Like, how do you distinguish that?
That's another great question. And I think I had a slide on, is this mind or body? Is this we think of somatization as a messenger system problem, a very real, something that's very real and physiological, but it's a messenger system rather than a structural problem. Then a lot of chronic medical illnesses are more structural. And when you have a physical symptom, it can be very difficult. And so I always give myself as an example that I have migraines, and sometimes those migraines are caused by more like things like a lack of sleep or certain thing that I ate or car sickness. And then other times it can be more stress related. And so over time, you can sometimes notice if stress is playing a role or when stress plays a role, and sometimes you don't know. So I would say with our pediatric with our kids, one of the goals of treatment is trying to understand yourself more and start to see some of those triggers and make patterns. And then regardless, even if you don't know, taking care of mind-body connection and all all the things that Amrit was talking about, Dr. Dhariwal was talking about in terms of, um, paying attention to your emotions and emotional things that help you out emotionally are going to help for your medical condition too. That's that both and approach. And we know that actually when people are recovering from a heart attack, which is a very structural thing, if they're psychologically supported, they do better. Their outcomes are better. So we get away from the mind or body, and we do mind and body.
Thank you so much. And someone asked, can this be combined with narrative medicine? If
I don't know what narrative medicine is. Do you, Andrea?
No, I am also aware of the time because I know we
Right.
have to go in
okay,
a minute.
that's
I don't know narrative medicine. I don't know. So I think this is an approach. My guess is yes. This is probably without knowing specifically. I think mind and body together approach and understanding our emotions and paying attention to our stresses is something that happens across all therapies and all of medicine.
all right, for sure. Okay, I know it's already 1:03, so I will just end the event here. For everyone else, Amrit and Andrea, are you okay if they have questions so they can just maybe send us an email? We can just pass it forward if that's okay.
Yeah.
All right, perfect. Sounds good. All right, great. So this is the official end to the event, everyone. We will send a recording to everyone RSVP'd. So if you want to rewatch it, that's available. And yeah, thank you so much for sharing your knowledge, Doctors Chapman and Dario. And thank you all for joining us, and wishing you all a lovely rest of your week. So,
Thank you so much. And I
bye.
like Tracy's comment that says this
Yes,
helps me remember to listen to my mind and body. So that's music to our ears.
for sure. All right. Thank you,
Thanks
everyone,
so
and take
much.
care. Bye-bye.
Bye.